In 26 years as a cardiothoracic surgeon, I have opened more chests than I can count. I have stood under surgical lights at midnight, working with quiet urgency on a heart that had simply been pushed too far. I have felt, with my own gloved hands, the difference between a heart that is coping and one that is losing ground. And after all of that, after more than 2 decades of operating on the consequences of what goes wrong inside the human chest, the thing that stays with me most is not the complexity of the surgeries. It is the preventability of so much of what I have seen. Because here is the truth that took me years to fully reckon with. Some of the worst cardiac damage I have witnessed on that operating table was not caused by a lifetime of bad diet. It was not caused by smoking or by genetics or by any of the usual suspects we reach for when something goes wrong. It was caused by medications. Pills prescribed with genuine care and good intention by physicians who were doing exactly what they were trained to do. Pills that, quietly and over time, were working against the very organ they were meant to protect. I want to talk to you today about 5 specific medications that millions of people over 60 take every single day. I want to talk about what they do that almost nobody explains, the trade-offs that get buried in the fine print, the depletions that accumulate over months and years, the conversations that a standard 7-minute appointment almost never makes room for. This is not about frightening you. It is not about telling you to stop taking your medication. It is about giving you enough understanding to walk into your next appointment and ask better questions. Because you deserve the complete picture. And right now, most people are not getting it. Before I go any further, I want to tell you about a man I will call Raymond. He was 72 years old, a retired civil engineer, the kind of man who approached his health the way he approaches work, methodically, carefully, without cutting corners. He walked every morning. He kept his appointments. He took his medications exactly as prescribed and never missed a dose. By every visible measure, Raymond was doing everything right. And yet he came to me 18 months after a cardiac event, describing a version of himself he barely recognized. The exhaustion he felt was not the ordinary tiredness of a busy day. It was a heaviness that did not lift after sleep, that did not respond to rest, that sat in his bones like something permanent. He woke in the night with muscle cramps severe enough to bring him fully awake, gasping. His thinking had become slower, not dramatically, not in ways that alarmed his family at first, but in ways that alarmed him because he knew how his own mind used to work. He had been told by multiple physicians that this was simply what getting older felt like. He had been told this so many times by so many people he trusted that he had almost begun to believe it. When I sat down with Raymond's full medication list, not just the highlights, but every drug, every dose, every supplement, I saw what was happening within minutes. Not one problem, 3 separate, simultaneous problems that had been quietly compounding for nearly 2 years while Raymond kept walking his morning miles and taking his pills and trusting that the system was looking after him. I want to tell you what those problems were, because Raymond's situation is not unusual. It is, in my clinical experience, remarkably common. Let me begin with statins. If you're over 65 in much of the Western world, there is a reasonable chance you are currently taking one. The names are familiar. High-dose versions of drugs designed to lower LDL cholesterol by blocking a specific metabolic pathway in the liver. And I want to be clear about something before I go any further. Statins save lives. For people with established cardiovascular disease, the evidence supporting their use is strong and consistent. I have recommended them thousands of times, and I stand behind that. But there is a consequence to how statins work that is mentioned on page 14 of the prescribing information and almost never in the appointment room. The pathway that statins block does not only produce cholesterol. It also produces something called coenzyme Q10, a molecule that functions, in the most accurate analogy I can offer, like fuel for your heart cells. It is essential to the energy production that keeps cardiac muscle contracting with strength and consistency. And statins, by blocking the pathway that makes it, reduce circulating levels of coenzyme Q10 by 30 to 50% in many patients. 30 to 50% depletion of the primary fuel source for the organ those patients are trying to protect. In a real human being, that depletion produces fatigue that does not respond to rest, muscle weakness, and cramping that appears for no obvious reason, mental fog that creeps in gradually enough that it can be mistaken for normal aging. In a significant subset of patients, measurable reductions in cardiac function. Raymond had been on a high-dose statin for almost 2 years. 2 years of his heart running on reduced fuel, while 3 separate physicians told him his symptoms were consistent with getting older. The straightforward solution, 100 to 200 milligrams of coenzyme Q10 daily, is available without a prescription. It has no significant side effects. It has real clinical evidence behind it, including data from large cardiac trials showing measurable improvement in heart function with supplementation. And yet coenzyme Q10 monitoring is not standard practice. Blood levels are rarely checked. Some insurance systems will not cover the test. The reason is not mysterious. Coenzyme Q10 has no patent. There is no financial incentive for the pharmaceutical system to build it into the standard protocol. That is not a conspiracy. It is simply how the economics of medicine work. But it means the burden falls on you to ask the question. Write it down before your next appointment. Should I be supplementing coenzyme Q10 given that I am on a statin? Just that question. It opens a door that would otherwise stay closed. Now, let me tell you about a second medication, one that surprises people when I raise it because it does not look like a heart drug at all. It sits in medicine cabinets in virtually every home. It is sold without a prescription, marketed for pain and inflammation, and taken by millions of older adults on a daily basis for arthritis, joint pain, and general discomfort. Anti-inflammatory pain relievers, the class of drugs that includes ibuprofen, naproxen, and several prescription-strength versions, are so familiar that most people do not think of them as carrying cardiac risk. That familiarity is part of the danger. Here is the mechanism. These drugs work by blocking specific enzymes in the body. One of those enzymes, when functioning normally, produces a compound whose job is to protect the walls of your blood vessels, keeping them flexible, preventing inappropriate clotting, and maintaining the kind of vascular responsiveness that blood pressure depends on. Block that enzyme regularly, and you remove that protection. Simultaneously, regular use of these pain relievers raises blood pressure by 3 to 5 millimeters of mercury on average. That sounds modest, but in a person over 60 whose arterial walls are already less elastic than they were at 40, a chronic 3 to 5 point elevation in blood pressure is not modest at all. It accumulates. It compounds. It raises stroke risk in ways that become meaningful over years. The regulatory agencies in several major countries have placed prominent warnings on these medications, specifically noting cardiovascular risk, not just gastrointestinal bleeding, but heart attack and stroke. That warning is on the label right now for any medication in this class that you might have in your cabinet. Raymond was taking one of these drugs every single day for joint pain. His prescribing physician was aware of this. The cardiac implication was never flagged. For people dealing with chronic joint pain, there are alternatives worth discussing with a doctor. Topical versions of anti-inflammatory medications applied directly to the skin deliver comparable local benefit with a fraction of the systemic absorption, roughly 90% less exposure to the rest of the body. High-dose omega-3 fatty acids at 2 to 3 grams of EPA and DHA daily have genuine evidence for reducing cardiovascular inflammation. A landmark clinical trial showed a 25% reduction in major cardiovascular events with high-dose omega-3 supplementation. That is a number that deserves more attention than it typically receives. The goal, again, is not to stop a medication without medical guidance. It is to know that alternatives exist and to ask about them. The third medication I want to discuss is one that roughly 15% of the adult population takes, often for years, sometimes for decades, without ever thinking of it as a drug with cardiac implications. Acid-suppressing medications, the type known as proton pump inhibitors, sold under several brand names, are taken by enormous numbers of people for heartburn, acid reflux, and related conditions. They are effective at what they are designed to do, but what they do extends beyond suppressing acid, and that extension matters enormously after 60. Your stomach acid is not simply an annoyance to be neutralized. It is a critical part of how your body absorbs certain nutrients, vitamin B12 in particular. Suppress that acid consistently over years, and you suppress B12 absorption, not partially but profoundly. Why does a cardiac surgeon care about vitamin B12? Because B12 is essential to the metabolism of a specific amino acid that, when it builds up in the bloodstream, directly damages the walls of your arteries. Elevated levels of this amino acid are an independent risk factor for cardiovascular events, comparable in significance to elevated cholesterol in some research contexts, and almost entirely absent from standard cardiovascular workups. A study published in a major gastroenterology journal found that long-term users of acid-suppressing medications have vitamin B12 levels approximately 30% lower than non-users. In a population that is already losing B12 absorption naturally with age, because the stomach produces less of the compound needed to absorb it as we get older, a drug-induced deficit layered on top of an age-related one creates a meaningful and measurable deficiency. That deficiency looks like fatigue. It looks like memory problems. It produces a tingling in the hands and feet that comes on so gradually it can go unnoticed for months. In prolonged, severe cases, it causes neurological changes that do not fully reverse even after supplementation begins. From a heartburn pill taken for 10 years because nobody checked levels annually. These acid-suppressing medications also deplete magnesium, a mineral involved in more than 300 biochemical processes in the human body, including the electrical signaling that keeps your heart beating in a regular rhythm. Low magnesium is directly associated with cardiac arrhythmia. It is also notably associated with nighttime muscle cramping. Raymond's magnesium level, when I finally measured it, was sitting at the absolute bottom of the reference range, technically within normal limits. So no one had acted on it. Technically normal is not the same as adequate for a heart that is working every second of every day without rest. If you have been taking acid-suppressing medication for more than a year, ask your physician to check your B12 and magnesium levels. Ask whether there is a plan to eventually taper off, because stopping abruptly causes a rebound effect in which acid surges back more intensely than before, driving people back onto the medication. A gradual, supervised taper is the appropriate approach. And if B12 is low, the most effective replacement bypasses the stomach entirely, a form of B12 dissolved under the tongue that enters the bloodstream directly, requiring no stomach acid at all. Raymond had all three of these issues running simultaneously. A statin depleting the fuel his heart cells needed. A daily pain reliever removing vascular protection and raising his blood pressure. An acid-suppressing medication blocking B12 and draining magnesium. 3 separate specialists had seen pieces of his situation. Not one of them had looked at the complete picture and asked what the combination was doing over time. The 4th medication I want to raise involves one of the most commonly prescribed blood thinners in older adults, used for irregular heart rhythms, blood clot prevention, and heart valve conditions. It has been in use since the middle of the last century, and for the patients who need it, it prevents strokes in ways that are genuinely life-saving. I am not questioning its necessity where it is necessary. But there is a mechanism of action that accelerates something I have seen with my own eyes on the operating table, and it deserves a direct conversation. This blood thinner works by blocking vitamin K. But vitamin K is not a single substance. There are 2 primary forms. The first is involved in blood clotting, which is exactly what the medication is targeting. The second form has an entirely different job. It activates a protein whose specific function is to prevent calcium from depositing in your arterial walls and to direct it toward your bones instead. The blood thinner cannot distinguish between the 2 forms. While blocking the first, it simultaneously blocks the second. And without the second form of vitamin K functioning normally, calcium begins to drift. It accumulates in vessel walls. Arteries that should be flexible become progressively rigid and calcified, like pipes slowly filling from the inside. A study published in a major cardiology journal found that long-term users of this blood thinner showed significantly accelerated coronary artery calcification compared to matched patients on newer anticoagulant medications. As a surgeon, I have seen what heavily calcified coronary arteries look like. The calcification changes the surgery. It changes the recovery. It changes the long-term prognosis. If you're on this type of blood thinner, there are two questions worth bringing to your next appointment. First, given the newer anticoagulant options available today, is this still the most appropriate choice for my specific situation? Second, has anyone measured my coronary artery calcium score? A single low-dose CT scan gives a precise, quantified picture of what is happening inside your arteries right now. It is one of the most underused and most informative tools in cardiovascular risk assessment. The fifth medication is the hardest for me to discuss. Not because the science is difficult to understand, but because I recommended it myself, confidently, routinely, for the first 15 years of my practice, and I was wrong. Calcium supplements. If you're a woman over 60, there is a substantial chance that at least one physician has recommended you take calcium for bone health. 1,200 milligrams daily with food for your bones. It sounds like common sense. It does not feel like a medical intervention in any significant sense. It feels like basic maintenance. In 2010, a major analysis published in the British Medical Journal reviewed 15 randomized controlled trials involving nearly 12,000 patients and found that calcium supplementation taken without specific companion nutrients was associated with a 30% increase in cardiovascular event risk. 30%. A significant number of people taking their calcium supplement faithfully every morning, believing they're doing something unambiguously good for themselves, may be meaningfully increasing their risk of a cardiac event. The mechanism is called the calcium paradox. When calcium is taken in supplement form, it enters the bloodstream as a sudden, concentrated surge, far more abrupt than the gradual release that comes from calcium in food. Without the companion nutrients needed to direct it, the body does not always know where to put it, and one place it ends up is the walls of your arteries. The same calcification I described with the blood thinner, but driven this time by the supplement itself. You take a pill to protect your bones. Under the wrong conditions, it hardens your arteries instead. Reversing a recommendation that has been given to tens of millions of patients over 20 years is institutionally complicated. There are liability questions. There are industries built around calcium supplement sales. There are guidelines that change slowly, if at all. So the information exists in the research literature, and it has not yet fully reached the appointment room. In my own practice, when I finally sat with that data and really understood what it was saying, I thought about every patient I had given that recommendation to. I felt responsible, not consumed by guilt over what I could not have known, but genuinely responsible for making sure that every patient going forward received the complete information. That is the only thing any physician can do when the evidence moves. If you're taking calcium supplements, particularly for documented bone density loss, the evidence-based approach is to take them alongside two specific companion nutrients. The first directs calcium away from arterial walls and toward bone, where it belongs. The second enhances absorption and reduces the abrupt surge effect. Wherever possible, dietary calcium, from dairy, from leafy greens, from small fish eaten whole, should be the primary source, with supplements filling genuine gaps rather than serving as the foundation. Raymond's story does not end in that operating theater. It ends 6 months after I sat with him for 40 minutes and went through his entire medication list, one drug at a time. We added coenzyme Q10 at 200 milligrams daily. His B12, which came back critically low, was replaced immediately using the sublingual form that bypasses the absorption problem. Chelated magnesium was added at 400 milligrams daily. His daily pain reliever was switched to a topical gel formulation. Same anti-inflammatory effect locally, 90% less systemic exposure. His acid-suppressing medication was tapered gradually under his physician's supervision. Calcium-directing nutrients were added alongside his existing calcium supplement. Nothing dramatic. No new surgery. No breakthrough drug. We simply stopped depleting the things his heart needed to function and replaced what had been lost. That was all. 6 months later, Raymond called me. He said, and I remember exactly how he put it, that he felt like he had been handed back to himself. The bone-deep exhaustion was gone. The nighttime cramping had stopped within the first month. His follow-up cardiac testing showed measurable improvement in heart function. His primary care physician called me genuinely surprised. The improvement did not fit the expected trajectory. Nothing had changed except that someone had finally looked at the whole picture. After 26 years of cardiac surgery, that is what continues to astonish me. Not how complicated the problem was, how simple the solution turned out to be once someone took 40 minutes to ask the right questions. The medications in this conversation are not villains. The physicians who prescribe them are not negligent. They are operating inside a system that rewards the initial prescription and has almost no mechanism for rewarding the follow-up. No time built in for asking what this combination is quietly doing over the next 2 years. No standard process for tracking the nutrients that individual drugs are gradually removing. You cannot change that system in a single appointment, but you can walk in with every medication listed, every dose noted, and 3 words written at the top of the page. What am I losing? Every drug has a trade-off. You deserve to know yours. That question, asked calmly, persistently, and with the confidence of someone who understands that the conversation has been incomplete, is where everything starts to change. Your heart has been working for you, without pause, without complaint, every second of your entire life. It has never asked for a break. It has never skipped its responsibility to you. The very least it deserves is your full attention and the complete truth.